In today's video, we are going over an evidence-based guide to cervical radiculopathy. Let's do it. This is part 3 in our series of cervical radiculopathy. If you missed the first part, I recommend going back in the show notes, in the description, and checking out part 1 and part 2 before you proceed. So what should the objective evaluation look like for patients that have cervical radiculopathy? Well, there's going to be 4 main things. After you do subjective, you probably want to take a look at manual muscle testing for myotomal weakness. We also want to see if you can visually see any atrophy in given muscle groups, because again, that's going to help us rule in a cervical radiculopathy. We want to look at sensory testing to take a look at dermatomal issues, right? We also want to take a look at deep tendon reflexes using your trusty old reflex hammer. And lastly, provocative tests or special tests like a Sperling or an upper limb neural tension test. We're going to go in depth on all of these. And now I've got a free guide for you today. It's an evidence-based cheat sheet to cervical radiculopathy. We go over all the fundamental basics for diagnosis and treatment of cervical radiculopathy. It's an 8-page PDF, and I'll take you from a novice to an expert extremely quickly. I'm going to leave a link in the description so you can go ahead and download that right now and get learning. And lastly, this cheat sheet was specifically made for the lesson today. So I have all of the bullet points in this presentation included in the cheat sheet. And this is really nice. So if you download it, you can follow along with today's lesson. And the other piece is that a couple months from now, if you're like, oh man, I kind of forgot what Dan said about cervical radiculopathy, you have a new patient coming in tomorrow, and you want to make sure you do a good job, you can just take a look at the cheat sheet, reference it, and just nail your examination. So we can use myotomes to help to figure out whether or not this patient in front of us has cervical radiculopathy or not. We can also use this information to try to rule in which level is going to be involved, right? So if people have an injury to the C5 nerve root level, we would expect to see some weakness into the deltoid as well as an elbow flexion. So if you have reduced shoulder abduction strength, and you also have reduced biceps or elbow flexion strength, we're starting to think this may be a C5 nerve root injury. Tongue twister. Sorry, guys. If we have an injury to the C6 nerve root, we can expect to see a little bit of weakness in the bicep, right? So elbow flexion could be limited, as well as wrist extension. Okay, so make sure you're testing those things. For C7 nerve root injuries, we expect to see a little bit of weakness of the triceps, so elbow extension, as well as wrist flexion. Injury to the C8 nerve root, you expect to see some weakness in the finger flexors or also thumb abduction. And lastly, an injury to the T1 nerve root level, we expect to see some weakness in the finger intrinsics, specifically first dorsal interosseous weakness. Now, I've actually already videoed myotomal tests as well as dermatomal tests and reflex tests, right? I will try to leave a link in the show notes in the description if they're published, but if they're not published quite yet, make sure you subscribe to the channel so you can be notified about when I actually release those videos. This way you can see exactly how I like to test for myotomal weakness, dermatomal changes, and reflex changes. Hong et al. In 2022 was looking at patients that were going to be undergoing surgery for cervical radiculopathy. So these patients that were about to go surgery for cervical radiculopathy had been thoroughly examined to try to figure out if the cervical nerve root was involved and which one, right? So they went through clinical testing. They probably had an MRI. They may have had some diagnostic injections to try to figure out exactly what nerve root was involved, okay? And then these patients using myotomes, you could only correctly identify the nerve root that was involved in 67% of all the patients. Okay. So basically, if I have a patient that's weak at the C5 level, I'm thinking probably the C5 nerve root. Although, at least in this study, we could only be certain in around 67% of those patients, right? So again, not a perfect science. So in this study, motor weakness of C5, C6 radiculopathy, so a C6 nerve root lesion, showed much more variance with typical motor weakness demonstrated in 47% of the patients. So in this study, the assessment of C5 shoulder abduction didn't have a very good correlation with an actual injury to the C5 nerve root. Also, patients with severe motor weakness, so think about less than a 3 out of 5, can't lift my arm up against gravity, or if they had obvious atrophy of the area, those with involvement of root C5, C7, and C8 showed a typical pattern, right? So C5, not so good. These other nerve roots, a little bit better. Only 2 of the 6 patients with severe motor weakness caused by C5, C6 radiculopathy fit the typical pattern, right? So again, C6 didn't really match up well at all with severe weakness. In C6 radiculopathy patients with severe motor weakness, 4 of 6 of those patients had weakness that did not conform to the standard pattern. So not only did the weakness not fit the area, but they were weak somewhere else. They were severely weak, but not in the dermatome, or excuse me, not in the myotome that they expect to be weak. So wrap your head around that, right? But myotomes, just like dermatomes, not a perfect science. So, as previously discussed in prior research from McCaney et al., about 54% of patients follow the standard dermatomal pattern. In this study by Hong, around 62% of patients were identified as having the standard dermatomal pattern. So, a little bit higher, but not by much, right? And when you're assessing dermatomes, what's the best way to do this? Well, when we're looking at dermatomes, we're looking for either reduced sensation. So when we test from left side to the right side, we're looking for a reduction in sensation or heightened sensation. So this could be just brushing lightly on the side of the shoulder and the patient just experiencing, whoa, that's a lot of burning. That's an intense sensation, right? This can be assessed via pinprick testing or light touch. We have a bit of research to show that those are both adequate. They're both decent ways of testing your patients. So you can choose either one. And again, we're assessing side to side. A positive test would be diminished sensations or increased sensation, like hyperalgesia. Like on this side, it feels like painful burning. On the other side, it just feels normal. So, in terms of where these dermatomes lie, you're also going to find a lot of variety in our medical literature. We see a lot of images out there where people are kind of striped like a zebra, right? And keep in mind that our dermatomal patterns aren't perfect. And what I also see is that these dermatomal maps are very different from source to source. Okay. Largely, when we're assessing the C5 nerve root, we're looking for pain or sensory change in the deltoid area and the lateral side of the upper arm. Okay. When assessing the C6 nerve root or the C5, C6 level, we're looking for some pain or sensory changes in the radial forearm to the thumb and index fingers. Excuse me, index fingers. When assessing the C7 level or the C6, C7 level, we should notice a mid-radial forearm to index and middle finger. I think middle finger is a very easy and very consistent finding with C7 injuries, right, across our medical literature. So looking for changes there. An injury to the C8 nerve root or the C7 T1 level should give you some ulnar forearm and ring and little finger sensory changes and or pain. Again, these findings are not perfect. And the other part is that we just talked, Bogduck said that pain should not follow a dermatomal pattern. So you can't always expect pain to follow that pattern. What Bogduck did not say, and he most certainly should have said, is that you should like this video as well as subscribe to the Fitness Pain Free channel. Bogduck will be very appreciative. So, reflex testing is also a way you can rule in or rule out cervical radiculopathy. The other piece is that we can help to figure out which level is involved based on which reflex test we use. Unfortunately, you can't use reflex tests to test every single nerve root. There's a few key ones where we can. The first one of which is going to be the C5 nerve root. We should have changes to the biceps reflex if we have an injury to that area. For the C6 nerve root, we should see some changes in the biceps as well as a brachial radialis reflex. An injury to the C7 nerve root, you should see a change to the triceps reflex. And again, I've taken videos on how to do all the reflex testing. So just make sure you're subscribed to the channel, and I'll leave a link in the description so you can check out those videos, or you'll be notified when those videos come out. So again, the biceps reflex is useful for diagnosing C5 or C6 nerve root injuries. The brachioradialis reflex is useful for diagnosing C6 nerve root injuries. And the triceps reflex is going to be useful for ruling in or ruling out C7 injuries. And lastly, a positive test is going to be a diminished reflex from left side to right side, involved to uninvolved. If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really, my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So, it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep seated reason is because you want to have the respect of your community. You want your clients to come in, work with you, and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the fitness pain-free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. And now back to your learning. We also have some great special tasks or provocative tasks in order to rule in or rule out cervical radiculopathy. The first thing I will say is that the sensitivities and specificities of these tests, and this goes for myotomes, dermatomes, and reflexes as well, they are going to be graded on a gold standard that's not always 100% accurate. What do I mean by this? So, in a lot of the studies where they're looking at sensitivities and specificities, their gold standard for the presence of cervical radiculopathy is going to be an MRI or an electrophysiologic test. Okay. And we know that these tests aren't perfect. And with MRIs, we know there are a lot of asymptomatic findings. So if you have an asymptomatic disc herniation, right, and that's supposed to be your gold standard for measuring these special tests, then we know that that data is going to be incorrect. All right. In some of these studies, the gold standard was in patients that are about to undergo surgery for cervical radiculopathy at a specific level. So they've probably had a clinical examination, MRIs, as well as diagnostic injections to try to rule in that nerve root level. Okay. So in some studies, the sensitivities and specificities are better than others, but also keep in mind that you're going to find these tests being measured up against a gold standard that may or may not be accurate. The other thing to keep in mind is that in these special tests, a positive special test was a reproduction of the patient's radicular symptoms, right? So if I do a Sperling's test, so I extend and laterally flex, it just feels a little bit tight within the neck, that would not be a positive special test. We need to provoke that patient's radicular symptoms. So if we do a Sperling's and we notice some numbness, some tingling, some paresthesia, pain that radiates into the arm, that would be a positive special test because it's provoking radicular symptoms. If there's a little central tightness just from doing this test, that's not positive, at least for cervical radiculopathy. So there's a bunch of good special tests to choose from. First of which would be a Sperling's test. This test had a specificity of 0.89 and a sensitivity of 0.98. So very, very good for ruling in and ruling out cervical radiculopathy. The traction distraction test had a specificity of 0.97, so very good for ruling in cervical radiculopathy, but a 33% sensitivity, so not very good for ruling the condition out. The upper limb neural tension test can obviously be done in a variety of different ways. We have tests for the median nerve, radial nerve, ulnar nerve, and multiple tests for the median nerve, right? The most sensitive test of the bunch was upper limb neural tension test 1. And then the most specific test was the ulnar variation. If you guys want to see the upper limb neural tension test in action, I will leave a link in the description for a video going over all of these tests so you know exactly what I'm talking about. Okay. So if you're going to use just one test that has high sensitivity, upper limb neural tension test 1. If you want one test that has a high specificity, that's going to be upper limb neural tension test 3 for the ulnar nerve. Okay. When you combine all of these four tests, they have a sensitivity of 97% and a specificity of 69%. So if you perform all of these tests on your patients with a suspected cervical radiculopathy and all of these are negative, there's a really good chance that the patient in front of you does not have cervical radiculopathy. The Valsalva test had a sensitivity of 22% and a specificity of 94%. So very good at ruling in cervical radiculopathy. The shoulder abduction test had a 47% sensitivity and an 85% specificity. The squeeze test had a 97% sensitivity as well as specificity. So this is actually a really, really good special test I've never heard of before. And if you guys want to check it out, go to the link in the description. I go over this test and how to perform it. So, where do x rays fall into the mix here for cervical radiculopathy? One important thing to keep in mind is that 65% of asymptomatic patients 50 to 59 years of age will have radiographic evidence of significant cervical spine degeneration, regardless of radiculopathy symptoms, right? We noted on this earlier. If we're relying on x rays to figure out if someone has cervical radiculopathy, it doesn't always tell the whole tale because a lot of these findings are going to be asymptomatic, right? The other piece is that, generally speaking, these are nerve injuries. So x rays don't pick up soft tissue injuries here, like nerves, right? So, why do we care about x rays if this is a soft tissue injury? Obviously, x rays aren't going to pick up nerves as a diagnostic test. Well, you can see how big the intervertebral foramen is. And if there's very little space given spurring, or let's say someone has a bony hypertrophy on the uncovertebral joints, then you will see decreased space and help to kind of rule in a given level based on the clinical findings as well, right? So they do have a little bit of value. So when would you consider looking at an X-ray or getting some X-rays? Excuse me, X-rays. Well, for one, when there are red flags apparent, right? And which red flags can you find with an X-ray? So you can find instability, right? So if you have a fracture of the neck, obviously that's something that's an emergency situation. You need to get some imaging to figure out if that's going on, right? The other one's going to be malignancy or some sort of cancer. So x-rays can actually pick up on that as well. So if you have a patient where you suspect they may have cancer, obviously refer back to the physician and they can do some imaging at that point. The other time when you can consider getting some extra imaging, like an x ray, would be if you had a failure of conservative treatment. So basically, if someone tries some physical therapy, has some time go by, not getting any better, let's say 4 to 6 weeks or so, we refer back to the physician and they can order some x rays. So the x-rays and later MRIs are going to be important because we have to figure out A, if this person truly has radiculopathy. But the other piece is if we're going to utilize an injection, right? So epidural corticosteroid injection, or if we're considering surgery, we have to know which level is going to be involved. An x-ray is going to help with that. When is an MRI useful in the diagnosis of cervical radiculopathy? So, just like with x ray, the MRI is not helpful in most cases of cervical radiculopathy because of its significant rates of false negative and false positive findings, right? So, if I have MRIs of the general population, I will find a lot of asymptomatic individuals that have disc pathology, that have decreased space in intervertebral foramen. And that doesn't necessarily mean that it's a problem. So it's a little tough to take the MRIs as this is the gold standard. We know this person has cervical radiculopathy because we see this disc pathology at C5, C6, right? So take that with a grain of salt. In asymptomatic patients over the age of 64, 57% of these folks have evidence of disc herniation and 26% have spinal cord impingement. So, when would you consider ordering an MRI? Okay. Generally speaking, same as x rays, when there are red flags apparent. So, if you suspect something like a myelopathy, abscess, or a patient has progressive weakness, in that case, we want to refer them back to the doctor because they may need an emergency surgery. Okay. Also, if you have a failure of conservative treatment, let's say you go through 4 to 6 weeks of physical therapy, no improvement whatsoever. Okay, let's send back to the doctor. Let's order an MRI. Let's get some more information about whether or not this person actually has cervical radiculopathy. Maybe they're dealing with something else we need to be aware of and treat it a bit differently. The other piece is, where is the nerve root that's involved if this truly is cervical radiculopathy? Because if we're going to do an injection or surgery, we want to make sure we do it at the right level. What about electrodiagnostic tests? So things like EMG. When would you consider using something like an EMG? Well, for one, they actually can be useful in trying to figure out which nerve root is going to be involved. It's not a perfect test, doesn't have 100% sensitivity and specificity, but it can be useful. The other thing that we can use is as a differential diagnosis tool when we're dealing with something like a peripheral nerve injury. So if you have some sort of entrapment syndrome a little further down the leg, so think about maybe like a piriformis syndrome versus a cervical radiculopathy, we can kind of tease out the peripheral nerve injuries with electrodiagnostic tests. So, like I said, these tests are not perfect. And at least in the lumbar spine, EMG has a sensitivity of zero point 0.5 to 0.85. So, not quite perfect. We can't say, hey, EMG results are this. That means they have cervical radiculopathy. We know that's not true. So, a few differential diagnoses where EMG might be helpful: carpal tunnel syndrome, that could be a median nerve injury, or it could be carpal tunnel syndrome, right? So, having carpal tunnel syndrome is going to mimic a C6 or C7 injury. If someone is dealing with cubital tunnel syndrome, this could be an injury to the ulnar nerve. However, it also could be a C8 or T1 injury. We're trying to figure out, is this a radicular issue or is this more of a local issue? And the last one is posterior interosseous nerve entrapment. So basically, it's an injury to the radial nerve, but not at the spine, right? And it can mimic a C7 nerve root injury. And the treatments are just going to be a little bit different, right? Think about carpal tunnel syndrome. We're probably going to brace that person. If someone has a nerve root injury, we're probably not going to put them in a night splint, right? So we want to make sure we're giving our patients gold standard treatments based on an accurate diagnosis. And if you are interested in giving your patients accurate diagnoses, you should like this video and subscribe to the Fitness Pain Free channel, where I'll teach you how to diagnose all sorts of stuff, not just cervical radiculopathy. I've also included a nice little table for you. This is from American Family Physician. It's a nice little table for differential diagnosis for you about cervical radiculopathy. It's pretty dang enormous. So I'm going to leave a link in the show notes so you guys can just take a look at this and you don't have to listen to me drone on and read this table for you. But yeah, you can have a bunch of different conditions that look like cervical radiculopathy. It's important you know how to differentiate amongst these things. Some of the heavy hitters here are going to be those peripheral nerve injuries like a carpal tunnel syndrome. You also might see some rotator cuff pathology, right? Shoulder pain might seem a little bit necky. We want to make sure that we're dealing with a neck issue and not a shoulder issue. Could be seeing some brachial plexopathy. So sometimes you get a stretch injury of the brachial plexus, and the injury is not necessarily at the nerve root, but a little further down, right? So more of a peripheral injury. Another big one that often mimics cervical radiculopathy is going to be thoracic outlet syndrome. And a lot of these conditions just have a different set of diagnostic tests to rule these in or rule these out. So now that you know more about cervical radiculopathy, you still need to know how to do all the special tests to rule in or rule out this condition. I have a great video for you. I'll leave a link in the corner right over there. Click on that and continue the learning. I'll see you on that next video. If you're interested in the references, I'll leave them in the description in the show notes. You can definitely check those out. Lastly, I just want to say thank you so much for your support. You truly allow me to do what I love for a living. If you're watching this on YouTube, please hit that thumbs up button. If you leave a comment, it helps the algorithm. I'd also love to know your thoughts on this presentation today. Please subscribe to the channel. It helps me out tremendously. If you're listening to the podcast version of this, please consider leaving me a positive review. Again, it helps tremendously. If you want to see more content like this in the future, we got to make sure we grow this over the course of time, right? And lastly, if you want to support me even further, consider subscribing to Fitness Pain Free Insiders. This is going to be my premium subscription membership to Fitness Pain Free, where all my best content updated monthly lives. So head to fitnesspainfree.com, click on the programs link, click on Fitness Pain Free Insiders online library, just $1 for a week trial. I'll also leave a link in the show notes in the description. All right, go ahead and check it out.